and welcome to the Postpartum Years podcast. I am your host, Dr. Ellen Kramp. I am a physical therapist and a pelvic health specialist. Joining me today is Cat Halek. She is an internationally board certified lactation consultant and a good buddy of mine. We've known each other for several years, and she has taught me tons and tons and tons of information about lactation and breastfeeding and bottle feeding. And I have given her information about how to manually treat the breast and how to manually treat babies who are having difficulty latching. So welcome, Kat. Thank you for joining me today. And today we are going to discuss mastitis. So, Kat, would you like to tell us what mastitis is?
Sure. So, thanks so much for that stellar introduction also, Mary Ellen. Mastitis is simply breast inflammation. So, there's different types of mastitis, and mastitis is kind of an umbrella term that includes engorgement, something called a phlegmon, galactoseals, blebs, and abscesses. All of those things fall under the umbrella, and we're going to go into more detail about that. Engorgement has two types, primary and secondary engorgement. Primary engorgement is typically, we think of it when a baby is first born. This secretory activation, which basically means the glands shift from making colostrum into producing more voluminous milk, more volume of milk about day 2. And women who have just given birth will experience breast fullness, swelling, sometimes pain or discomfort around engorgement. And then there's also secondary engorgement, which is any time that the breasts basically are just full or swollen or uncomfortable after that initial 2 weeks postpartum.
Okay, so with secondary engorgement, that is a little bit different from primary engorgement, and a lot of it happens to be more the way that milk is managed versus primary engorgement isn't quite the same.
Yeah.
So explain the difference with that.
So primary engorgement in natural vaginal childbirths without a lot of IV fluids is more about the glandular tissue swelling and actually like the milk coming in, which is what people think engorgement is in general. In hospital-based births, it's more than just the glands and the milk turning on. It's actually some of the third spacing, which is basically the IV fluids trying to find a place to go in the body. I had a C-section. I know that they poured 4 liters of fluids into me within 10 minutes right before I had my C-section. And I definitely feel like that the body wants to find places for that fluid to go. So primary engorgement is common. It's not necessarily normal. With really great vaginal natural childbirths, it doesn't always happen. It still happens sometimes with vaginal and natural childbirths, but it's more common in medicalized hospital births with a lot of IV fluids. So that's primary or pathological engorgement. Secondary engorgement, as we'll see, is more about mismanagement of milk supply, or sometimes it's simply you slept for 5 hours instead of 2 hours and you wake up and you're a little full and uncomfortable.
Now let's talk about the stash culture, which is also a problem with secondary engorgement.
Definitely.
As well.
So I've been a lactation consultant and working with feeding families for about 13 years. When I first started, the Affordable Health Care Act had not come about. So people that had money were able to buy their own pumps. Most people that were breastfeeding, once they went back to work, they figured out other ways, or they started supplementing formula. What happened about 2000 2012, 2013 is the Affordable Health Care Act actually trickled down into actual practice. And lactation benefits was a huge shift in insurance. But the way that the insurance companies decided to interpret that was everybody gets a pump. You get a pump. You get a pump. Everybody gets a pump. And there was a shift in my practice working with these families of most people that were breastfeeding were like stay-at-home moms, or they, I worked at WIC at that time. We were able to give people pumps then, but in my private practice and everywhere, everybody was getting these pumps. And so there was this breakout of people right as soon as they gave birth to the baby, not focusing on breastfeeding directly, but focusing on breastfeeding and pumping. And it started to create oversupply. And you know what else was happening around 2012 to 2014? Social media really became mainstream and everybody was on it and much more. And so people, as they're having their babies and they're bragging about their milk supply, they're posting these pictures of 8-ounce bottles and all of this stuff. So having a stash became a status symbol. They even call them milk bricks, like bricks of money or like bricks of drugs. Yeah, I've got like 2 bricks up in the fridge, and I'm like, okay. And the funny thing is, I've been doing this long enough that like mentally I'm picturing, okay, so they've got about probably 20 to 30 ounces in one brick and another 20 to 30 ounces in the second brick. So stash culture and the need to have a lot of milk for the future when you go back to work became a big thing. And so people started pumping way earlier than they should have, which is like, really, we don't advise pumping unless you're being advised because there's a reason to. We don't really advise pumping in that first 2 weeks. During that time period, I joke with my patients and my clients that you're making milk for a small village or like quadruplets. And that's normal. But if we include pumping on top of that, which most people will do because they want to stash or they're full and uncomfortable with engorgement and they think like, oh, moving the milk more is going to help that, it creates oversupply. And like I said, so like 2012 to 2014, prior to that, there was not as much plug ducts, galactocells, phlegmons. That was not happening as much. It was happening, but it wasn't happening as much. Now it is so common, not normal, for women to experience plug ducts engorgement, painful engorgement, and lots more issues and nipple blebs because they're pumping way earlier and a lot of these women are having oversupply. Trying to get it into people's heads that you want like Goldilocks for milk supply. You don't want too little. You don't want too much. You want just right. That's the goal, is really hard. And they're like, but what's wrong with oversupply? But why can't I have more milk? Isn't more milk better? And I'm like, oversupply and more milk is its own problem. And I tell them in my community practice, in my private practice, I would say about 30% of my clients, I'm helping them manage oversupply.
And there were a lot of recommendations out there as far as engorgement. So let's look at first, what are the outdated recommendations?
Yes.
So people know that if they hear somebody saying that okay, yeah, that it's existed, but it's really outdated.
Yeah. So the biggest thing with engorgement was that we used to think that stagnant milk, like milk not moving enough, was causing all of these problems instead of simply like inflammation and breast dysbiosis. And FYI, dysbiosis, we're going to go into that a little bit later, is simply like the good and the bad bacteria in the breast is wonky. It's too much bad, not enough good. So heat is a big one, and it is still recommended to this day There was a woman that was admitted to the hospital where I work at through the ER for sepsis because she had mastitis and she let it go way too far before getting help. And the doctors were recommending heat. Mind you, they didn't consult lactation because we would have told them, no, use ice, please. So heat's one of them. And like we have a picture of a heating pad. Literally, I have seen people put a heating pad on their breasts. And what that does is, so heat expands things, cold contracts things, right? Heat just swells things up. It feels really good, and so that's why people keep using it and keep doing it, is that immediate sensation after using heat, you feel some relief. Or going into the shower and putting your breasts directly under the hot water, you feel some immediate relief from the heat. But long term, you're just causing things to swell. And then you put on your tight bra that doesn't fit you, and your breasts kind of like mold into that shape. And I've seen some like really strangely, oddly shaped, hard breasts from heat and then wearing a bra. Just very, not natural. They look like bricks or blocks or like angled weird, depending on the bra. So another one is called therapeutic breast massage. And therapeutic breast massage is kind of like when you don't have an awesome professional like Mary Ellen that can do, skilled massage. So it's outdated, but at the same time, it's still, it might have its place sometimes. There's also something called breast gymnastics, which is literally like going like this with your breast, like just kind of moving it around. That actually, with the Academy of Breastfeeding Medicine's protocol, is really not recommended because once again, we're manhandling or we're being too rough with the breast. So again, massage or massagers in unspecified, like they don't know what they're doing. Usually parents just don't know what they're doing. Or sometimes the lactating parent's partner is trying to help out with massage. I had a couple in outpatient that the dad was being way too rough, and I had to like demonstrate on his leg, like, no, you can help her massage it, but you need to be way more gentle. And he was like, okay, got it. So again, that increased milk removal, we don't really recommend that because it's not a stagnant milk situation, it's inflammation. Just simply inflammation most of the time. Cabbage. So cabbage is still used. I mean, when you peel off a cabbage leaf, it is kind of breast shaped. But really what the research and the science is telling us is that it's the cold of the cabbage, not the cabbage itself. We also used to think that the cabbage had some sort of like an enzyme that would help dry up your milk, or that would help the milk engorgement like go down a little bit. I just saw this on social media where a lactation consultant was actually recommending it, and somebody in the comments was like, don't do it, it will dry up your milk. Well, no. But the reason for not doing the cabbage is that people don't have the best hygiene, and cabbage can carry listeria. So imagine you have swollen, engorged breasts, and maybe you're having difficulty with latching or pumping. Your nipples are sore, there might be open wounds in it, and then you slap some cabbage on it that has listeria. And then you have another problem because then you are contaminating your milk, and also you might have that infection in your body. Binding is another one, and once again, at this hospital, I got a voicemail like maybe a month ago from a medical student that was working in OB and was like, hey, this mom isn't breastfeeding, and so I need you to come over here and bind her breasts so that they won't make milk. And that's just not what we recommend anymore, especially if you ever want to lactate again. I have, in my 13 years of clinical experience, seen women who did extreme measures to stop their milk supply with binding and or cabbage, and they massage and they damaged their breasts. And then with subsequent pregnancies, when they did want to breastfeed, it caused issues and damage, and there was fascial restrictions and vascular restrictions. Mary Ellen, there is a Theragun in this slide, and tell me what you experienced when you were working with somebody that used a Theragun on her breast.
Oh, some of these Theraguns are more gentle than others. Um, Most of them just aren't the most gentle thing. And one of Kat's favorite things to say is the breast is a gland and not a
Yep.
muscle. Would you beat the snot out of your thyroid gland?
Nope.
No, you wouldn't.
Nope.
So please don't do it to your breasts. The the gland and the lactiferous ducts are small, and they have enough problems with compression from bras that don't fit. They have enough issues with tension that might be in the breast from doing sports when you're younger. Playing soccer. How many times did you take a hard soccer ball to the chest? Well, some of these women have a lot of trouble with mastitis because the breast tissue, instead of being nice and open, the connective tissue is really tight in there, and it's impeding the way everything should be growing and filling and how milk should be getting out. So smashing it with a Theragun, I do not recommend.
Yeah. And didn't you have a client that was using a Theragun and it actually made her have like a galactocele that got really, really bad? And
Yeah.
yeah.
And needed draining.
Yeah.
Yeah.
Yeah. So
So, yeah, please.
no heat,
Please.
no cabbage, don't increase pumping, don't increase feeding, don't bind, don't use a massager or a Theragun.
The more traditional recommendations that are out there that are still helpful. The first one is going to be ice because, again, as you were saying, shrinking the swelling. So rather than taking out the cabbage, take out a bag of frozen peas and mold that over your breast. And that is going to be much more effective for decreasing the swelling and inflammation that's going on.
The breast dunk method, I was in a training, and this is back in like 2012 or 13, and they said that like at that point in time, the only researched method for engorgement was this breast dunk method. And so basically, and I've worked with families. I've done this breast dunk method in people's houses and in their homes when I visited them. It's kind of not the best logistically. It's a great idea, but it's not the best logistically because you have a newly postpartum body, and leaning over a bowl of hot water or warm water and bending and dunking your breasts repeatedly, it may not be the most comfortable thing if you've had a difficult labor. And so basically what you would do is you would put like a big basin or a pot of water, make it warm, very like not hot, but warm. And then you dunk it, and like the gravity and the heat and the rest from the heat and then the gravity and the heat, it can trigger a letdown and it helps the milk flow. I don't really recommend the breast dunk method anymore because I know how to do lymphatic drainage because of working with you. So I usually try to teach families that instead of the breast dunk method. And that's much easier to do with a postpartum body than to like bend over something and repeatedly dunk your breasts into something. And also, let's just think about like different sizes of breasts and shapes of bodies. That, if you have breasts like that are in this picture, which are a little bit, bigger and more pendulous, it might work. But if you are a part of the itty bitty titty committee, and you don't have anything there, it's not going to be as effective. All right. So, I have my little crocheted breast, and I want to thank Mary Ellen's daughter, Elena, who helped, make this breast for me. So this breast, what you would do is when the swelling is so severe, when you try to latch a baby onto a really tight engorged breast, it's like they're trying to bite a basketball. Like you can't grasp it. It's like it's hard. You're like ah, or trying to like latch onto a wall. It's not really possible. And so what I recommend and is really common and still good practice is to kind of put your fingers around the base of the nipple and push firmly back. Firmly back. Okay? Sometimes the full method that you'll see if you Google reverse pressure softening is too much for a newly postpartum mom who's experiencing engorgement to handle. What I like to tell people to do is wherever the baby's lips are going to go, just kind of make like a little peace sign. So if like the nose is going to be here, the upper lip is going to be here, the lower lip is going to be here, and then just firmly press back. I don't like pain, and I don't like pain with breastfeeding or pumping, but if you're engorged and you firmly press back, that might be tender or uncomfortable, but it's well worth it so that you don't damage your nipple. So that's my like I when I'm working with people and I'm showing them reverse pressure softening, I'm like, okay, I don't want it to hurt, but this might be a little painful, and that's okay because we're trying to prevent pain and reoccurring pain. And that just softens and allows the nipple to get a little bit looser so that the baby isn't biting a basketball. It actually has a place, and then that nipple can be pulled and suckled, and it becomes more erect and the baby can eat better.
And now let's move on to the current recommendations. So the current recommendations are going to be lymphatic drainage and ice. And I just covered ice previously. Grab a bag of frozen peas, throw it on there. Lymphatic drainage, I'm teaching other physical therapists and occupational therapists how to do this. There are certified lymphedema therapists that know how to do this really well. Problem is they typically work with the cancer population and not so much with the postpartum population. So I'm trying to work in the pelvic realm to get those therapists to start working more with breast care and helping their new postpartum moms, or I mean, even months out down the road, how to do lymphatic drainage for these engorged breasts and for those with mastitis where they may have lymph drainage. And I may be making some videos in the future on how to do some self-lymphatic drainage for women to be able to do it on their own. But those are definitely the current recommendations for engorgement. Now moving on to plug ducts. I left this more scientific looking slide in from a presentation that Cat and our friend Barbara and I did at the National Conference for the American Physical Therapy Association last year on mastitis. And I left this one in because I think it shows a really good picture of what a plugged duct is going to look like and how it happens. In the top picture, there is the lactiferous duct. So that is the duct that the milk is going to come through. The gray area on there is the side of the duct, or you can see the circular cross section there of the duct itself. And then the white in the center is that section where the milk is going to flow through. That is it's called the lumen. And all the different colored dots in there, that's the normal bacteria, normal yeast that lives within the wall of that lactiferous duct. And they're, just kind of like your lawn. You have grass, you have dandelions, you have clover, you have, whatever you may have in the area wherever you live. And they're all kind of living there happily. When mastitis occurs, there's an inflammation. So if you look at the walls of the duct itself, they're thicker now, which makes that lumen, that opening, even smaller. So, I mean, those openings are pretty small to begin with, but this makes it even smaller. And if you look at the bacteria along there, that bacteria has overgrown. So it's like the dandelions are out of control in the lawn. They're naturally there, but it's like you give them space, they're going to take over. So you have the bacteria that has kind of overgrown and taken over, and that narrows that opening even more. Then you can get to the point where it just really overtakes it, and then that lumen is closed. And if you look at the bottom of the slide, that's showing you how there can be this backup of milk behind there, and that's going to be that very traditional plugged duct that people think of, and they think every plug duct is like this, but it's not. It's under the umbrella term of plug duct, but this is actually called a galactocele, and this is how that ends up forming. So you have a closure of the duct, and then you have milk stuck behind there that can't come through.
I think it would be helpful for people that are just listening to think of it like a duct is like a strand of hair, okay? And or like a straw, right? So like imagine like you have like a straw and fluids moving freely through it. And then when you have that inflammation and you have the dysbiosis where there's too much bad bacteria or yeast and not enough good bacteria, and it starts to get narrowed, it's like you're like pinching the straw. And then what we feel in our breasts, which is like the hard lump that, people will call me and be like, hey, I got a plugged duct. What they're feeling is what gets backed up behind that in the straw. And it can really stretch the straw out also. And so when we're working with plug ducts, the goal isn't to push that plug out through the nipple, which people try to do. Another thing I like to, like another analogy I like to do to like try to imagine why that would not be a good thing to do is imagine like you cut open the top of a tube of toothpaste and you put like a marble that's like larger than the diameter of the tube of toothpaste opening. And imagine just trying to like push it out through a smaller hole. You're causing a lot of damage to this really fragile ductal system in your breast. And even if it does come out the nipple, ow, holy cow, ow, wow. Like that just, it just sounds awful to me. And what's interesting to me is that I've actually had a client that did that. Like she tried to like manually push through the nipple, and she sent me a picture of it, and it looked like to me, it looked like an alveolar gland that she had literally pushed out through her nipple. Yeah, really, really not great. So once again, the breast is a gland, not a muscle. We want things not to hurt. When they do hurt, we want to be gentle with them. We don't want to be overly aggressive. Not to call out military people, but her philosophy of pain was pain is weakness leaving the body. So she thought that if she could get the weakness out of her body, that things would improve, which she had chronic issues with breast health because of how aggressive she was with treating her breasts.
How about we move on to how these plug ducts happen?
Yeah, let's move on.
let's move on. Let's move on.
All right, so how do plug ducts actually happen? In all of these pictures, the latch is not phenomenal. People sometimes will think that suffering through a poor latch is going to be helpful. It actually causes a lot of issues. So not having an effective latch, not having a deep latch, causes poor milk removal by the baby that's eating, and then that can cause plug ducts and engorgement and mastitis issues.
In two of these pictures, the mom has just thrown a breast out on top of her clothing, and has the clothing kind of pinching off areas. Probably in that baby that's 3-4 months old that's nosy and looking around, it's not going to be as big an issue on that one. But for that newborn that is just learning to latch, and those breasts that are just learning to empty, I see those problems.
Yes,
Those problems definitely
definitely.
happen.
And in the third picture, the baby's hand is like in the way, and it just makes it so that the baby's not as deep as it should be.
Poor milk removal can be happening via the infant and the clothing, but it can also, I see it also many times with women who are exclusively pumping.
Yep.
So there can be poor removal by the pump.
Yes. Once upon a time, the pump companies thought that women's nipples only came in like two or three sizes. With, everybody getting a pump and more people pumping, which is a wonderful thing so that we can continue to lactate and give our babies breast milk after we return to work, we have found out that there are many, many, many different sizes and shapes to nipples. But continuously, the standard pump comes with like one or two flange sizes. And oftentimes, when somebody's having nipple pain or issues with pumping, they think bigger is better. And so I'm often finding women pumping with way too big of a flange size, and then a lot of breast tissue is getting into the tunnel of the flange, and it's causing issues. I also see people using way too small of a pump flange. Like their nipples are like, it doesn't match up. And that can also cause nipple trauma, damage, and poor milk removal by the pump. Another way that I commonly see poor milk removal by the pump is the idea of, well, if I can, turning the suction way too high, like way too high, and it's painful. Like like somebody's like, gritting their teeth and like, white knuckling while they're turning up the suction higher and higher and higher. The goal of pumping, when you're pumping, is to go to the highest suction level that is comfortable, not tolerable. So we don't even want it tolerable. We want to, like, if you get to tolerable, go down a couple of notches on the pump. Like, go down on the settings a little bit more. Also, a lot of families will come to me and they will say, well, I was on Instagram or I was on Pinterest and I read this, if I pump on this setting with this speed of suction and that suction and for this many minutes, and then I change this and then I do that and then I do this, I'm going to get 8 ounces out in 10 minutes. And everybody's breasts are different. Really, it's about like being patient and exploring and playing with your breasts to see what works while not damaging things by turning the suction up way too high or using an incorrect flange size. Another thing about flange sizes that I feel like is pertinent and like our audience would appreciate, Mary Ellen, is sizing a flange is not just about the measure of the base of your nipple. So if you buy a kit with inserts offline, or if a lactation consultant in the hospital or in your home comes and puts like a little like circle ruler up to your nipple and says, you are this flange size. It is not true. It could be up 1 or 2 millimeters. It could be down 1 or 2 millimeters. Nipples are erectile tissue and they change as they're being sucked. So when the vacuum is is pulling the nipple with the pump, it's going to change how big it is. And same thing with, when a baby is at the breast too. Like sometimes, the nipple gets a little softer, gets a little longer, maybe swells just a little bit. Measuring the base of your nipple gives you like a starting point for what your flange size is. But depending on your breast, the pump, what's going on, if you have any nipple damage, you may need like 1 to 2 sizes bigger or smaller than what you're measuring. And so I recommend not throwing away flange sizes unless you're like measuring a 13 and you have a 27. You can throw the 27 millimeter flange size away, but like it'd be good to have like a 13 millimeter and a 15 and maybe even on the odd day a 17. You never know. Exclusively pumping moms often will have more swollen nipples because just of how much repeated sucking that isn't a baby is happening. And so sometimes they might need to go up a size for a day or two when they're having some nipple discomfort and then go back down a day or two later to like a slightly smaller size. So I think that that's helpful information to know about pumping and how that can interact with poor milk removal and how that can lead to plug ducts.
And on that topic of wrong sizes, if we go into ill-fitting and restrictive clothing,
Yes.
those breasts really grow during pregnancy. And, going out and getting different bras during pregnancy and going out ahead of time and getting that nursing bra while still pregnant ends up being a problem because most women, especially first-time moms, don't understand how the size changes postpartum. So this can be a huge problem, especially with a lot of women who don't understand what bra size they should be wearing in the first place.
When they're not pregnant or breastfeeding.
Oh, I know. And commercials and ads really do not help this at all whatsoever.
Nope.
I mean, we've got a couple of pictures here from ads that it's laughable how these bras are fitting these women. And I always want to scream, like, give the girls some room.
Yes, let them breathe.
Let them breathe.
Let them breathe.
I also have to laugh at the other picture we have because I have lost track of how many of my mastitis patients I have seen who literally have been bridesmaids in a friend's wedding. The baby's almost always 6 weeks old for some reason.
Oh, yeah.
They're trying to wear a strapless bra or some other bra that is not going to fit. They are away from the baby because mom probably has the baby for the night, and they're drinking alcohol. They're not drinking enough water. They're not pumping. They're sleeping late. They're missing pumps. And they inevitably end up with mastitis in these situations. So between the ill-fitting bra, the dehydration, the alcohol, the missing pumping or poor pumping, it just ends up being just the perfect storm. So if you're listening to this, please, if you're going to be in a wedding, wear the appropriate size bra.
Yes.
Drink plenty of water. Even if you drink alcohol, drink plenty of water.
Yes.
Please pump on schedule. Please
Yes.
pump on schedule. And, even if you're going to get good sleep, please pump. Please.
Yes.
Please. Beyond ill-fitting clothes, recent or past trauma. Now, I talked about the trauma of, growing up playing sports like soccer or volleyball, basketball, ice skating, and you're falling on your chest. There can be certain traumas. I know you have seen plenty of women who have been in car accidents and they have a seatbelt trauma. I see a lot of women who wear like really heavy backpacks and across the chest and shoulders where they've had compression from those really heavy backpacks over time can compress the lymphatic flow.
Yep.
And there's a lot of breast tissue that goes really far to the sides and almost into the armpit. On some people, it's like really, really far back.
Yep.
And that can create a lot of trauma and prevent good milk flow and lead to mastitis in some people. So going on to the specific types of plug ducts. We had mentioned these earlier. Phlegmon, very traditional one, like I talked about earlier, is the galactocele. So that's the milk stuck behind the straw, behind that lactiferous duct. And the phlegmon is more diverse. It's inflammation within the breast. I mean, this breast may still be red and swollen and hard. There may be a lump or two. You may be able to feel some lumps, but it's the inflammation is more the problem. If you've ever known anybody who's had cellulitis, that's more what this is more of a cellulitis, but there can be fluid collection. So if I were to take my ultrasound to look at your breast, with a galactocele, I'm going to see a collection of fluid. And with a phlegmon, it's just going to be more inflammation with a couple of pockets of fluid and not like this very specific fluid. If we move on to blebs, that's going to be basically a clog or blister at the nipple itself. And then an abscess is a true bacterial infection. That is nothing for a lactation consultant to deal with. That is nothing for a PT to deal with. That is for a physician to deal with, and a specialist physician at that. Yeah. They often in the ER, they're going to call in a breast specialist to deal with that abscess. Kat, would you like to discuss the outdated recommendations?
Okay, so again, these breast massagers and gadgets that we're using to abuse our glandular tissue that's in our breast that is not a muscle. And this is like an advertisement from Amazon, like a little screenshot, and it's like lifelike kneading massage. We don't need to knead the breast. We need to treat the breast gland gently, okay? Very gently. Again, increased milk removal. Increased milk removal by breastfeeding more frequently or pumping is simply going to cause more oversupply. More oversupply causes more dysbiosis of the breast, which is more bad bacteria than good bacteria, and it's just going to perpetuate the reoccurrence of these plug ducts. Extraction of the clog through the nipple. I went into great detail. We're not going to keep going with that.
Yeah, please don't.
I know. The use of suction and Epsom salts. So if you Google, I have a plug duct or I have a nipple bleb or whatever, in this silicone pump called a Haka, you put Epsom salts and then you're supposed to suction it onto where the clog is or on your nipple where the bleb is, and it's going to pull it out or it's going to remove it or it's going to make the inflammation go down. It does not. And it actually can soften the tissue in a negative way that makes the tissue of the skin of the nipple or the breast more prone to breaking down and like ripping or tearing or abrading, to where there's an increased chance that we might have just had a normal plug duct and now we might get an infection. So it's not recommended anymore to use suction and Epsom salts on the breast. Some more holistic or natural-minded practitioners, they will recommend like a castor oil compress or heat compresses. Again, heat's going to expand. And also like castor oil might soften the skin and make it break down to the point where we are increasing the chance of getting bacteria that could make things worse. Another thing is like, we don't need to treat all of these plug ducts the same. It's not the same. Like a phlegmon and a galactocele are different. A galactocele and an abscess is different. One thing that I want to mention about abscess versus galactocele is that typically with an abscess, around the margin of where you feel the hardness, there will often be like a bluish green discoloration at the edge. And that's something that like we're taught as lactation consultants is like, okay, if we see that, we need to refer to a breast doctor or we need to refer to a doctor, because that's looking, we're tipping into abscess territory, and that's, beyond our scope to treat because we don't prescribe medications or do drainages.
Full disclosure, I am not a fan of ultrasound. I did my master's thesis on ultrasound, found it to be crap. Haven't been a fan for the past 33 years on it. So I did go through the ultrasound studies because this is traditional treatment for, from a physical therapist for mastitis and engorgement. And I was not at all impressed with the ultrasound studies that were out there. They were very small. They often did not have a control group because ultrasound is super easy to do a control group because you're putting on the same gel, you're making the same moves, but you're just not adding the heat. And the other problem I have is here we don't want to add heat to the system. Ultrasound adds heat to the system. So I have a really hard time saying we should be recommending ultrasound. I think the only reason it's even a recommendation is because there's a couple of studies out there, and they're crappy studies. Um, and it's the only thing that was really done. So therefore, it's the standard because it's the only thing that was done and researched. We do have research on lymphatic drainage, and it's mostly used for the breast cancer population, but we can drain things very, very quickly. There's tons of studies out there showing that lymph drainage and also that fascial releases are effective. They're just not geared toward the breast population. And research is very slow to catch up to what is being done. So, to get to the point where we can show that lymph drainage and fascial releases are great for this population is probably going to be beyond my lifetime. All right, let's talk about other outdated recommendations for mastitis. Cat?
Yes. So traditionally, years ago, like 10 years ago, somebody calls me and says, I think I have mastitis. And I ask them, like, are you having fever or chills? Like, is it just a pie piece of your breast that's red and inflamed and hard? And I would recommend, okay, if you caught it before you got sick, like the fever and chills, what you need to do is just rest, do skin to skin, increase breastfeeding, like just be in bed and just breastfeed. Or if you're pumping, pump. The more you pump, the better. The idea is, remember that old-fashioned, we thought that what was happening when we were having mastitis is that we have stagnant milk. And so if we have stagnant milk, if we move the milk, if it's not stagnant anymore, we're going to have benefits. The next step, if there is fevers and chills, it's still outdated, is within 24 hours, if it hasn't gotten better, then we are recommending antibiotics immediately, very quickly.
One thing that the the Academy of Breastfeeding Medicine was saying that they were finding with a lot of these women that the fevers weren't actual fevers, but fluctuations in hormone levels. So what was being labeled as a fever was a hormone fluctuation, kind of hot flashy type stuff, and wasn't actual fever. So the Academy of Breastfeeding Medicine is trying to be really helpful with antibiotic stewardship and not prescribing antibiotics when they are not needed. So, the thought was to prevent milk stagnation and get rid of that, the infection, but they were finding that most of these cases were inflammation and not infection.
Yes. And people, like, I've had conversations with people, and they'll be like, oh, well, maybe it wasn't infected, but I took the antibiotics and it felt better. Well, antibiotics do have some anti-inflammatory processes to them. And so that might be why, like, there was relief, even if there wasn't, like, bacteria that needed to be killed by the antibiotic.
Further traditional recommendations that are still helpful, you will advise women with soy or sunflower lecithin quite often.
Yes. It's soy or sunflower lecithin. If you read a packaged good, like even like chocolate or like a granola bar or something, you're gonna see usually it's soy lecithin that's listed in the ingredients. Lecithin is an emulsifier. It basically just makes things a little less sticky. And so when we're having reoccurring plug ducts, I don't necessarily recommend it after just one bout of plug ducts or mastitis. But if it's like it keeps happening, then I'm going to recommend for somebody to take soy or sunflower lecithin 3 or 4 times a day for a week. And then you try to go down to 2 times a day. And then you try to go down to 1 time a day. And then you try to stop it so that you're not just constantly taking something. Also, anti-inflammatory diets like inflammation. Mastitis is breast inflammation. If you have less inflammation in your body, you're going to have less inflammation. So, eating healthier, less processed foods, less fried, fatty, less processed sugars, stuff like that. Think like a Mediterranean diet is a low inflammation diet. And then in addition to that, so sometimes alternative breastfeeding positions might be helpful. So if you have like a localized plug duct that's, kind of more of that traditional galactocele that we've been talking about, putting the chin or the nose of the baby in alignment where that plug is can kind of help work it out and help, the glands release and relax and some of that fluid go back into the body, and then also release that little tight, like little globby plug that's causing everything to back up behind it. So it's still a helpful recommendation sometimes.
Alrighty, we have so much more to discuss as far as mastitis. So we're going to take a break here, and you can join us next time for part 2 on the Postpartum Years podcast discussing mastitis.